fast, it's because I'm trying to get this done in an hour. I've got 73 slides to go through, so let's see how I do. We've been talking about drugs, mostly illicit drugs and addictions and whatnot. Today we're going to talk about the pharmaceuticals that people take, the psychotropic medications. These are all pharmaceuticals that we're talking about. This is something that when you become a psychologist, that you're going to be dealing with what medications people are taking, Zoloft, Prozac, Xanax, whatever. So we're going to talk about some of the ones that they're using right now and some of the old ones because some people are still taking tricyclics. Some people may be on monoamine oxidase inhibitors, and you need to know what these things do, what we're talking about here. So let me go ahead and, what is this? All right. Oh, there it is. I'm sorry. I'm in such a hurry. Okay. The mechanism of action, SSRIs, we're talking about SSRI antidepressants. SSRIs inhibit serotonin reuptake so that they increase the synaptic serotonin levels. And because they can't reuptake, the serotonin stays in the synapse. Many SSRIs affect other receptors, especially at high doses. SSRIs clinical effect usually takes weeks, so the mechanism goes beyond simply increasing synaptic serotonin levels. There are several serotonin receptor sites. This is the 5-HT is what serotonin is chemically. Serotonin receptors are located throughout the body, especially in your gut, in your GI tract. All SSRIs except Luvox are FDA approved to treat depression, a major depressive disorder, and dysthymia. What used to be dysthymia, we don't really. Dysthymia fell out of the DSM-5 now, and along with neurasthenia. Now it's what do they call it? Depressive disorder. My brain's not working right this second. Various class members of SSRIs are also approved to treat generalized anxiety disorder, obsessive compulsive disorder, panic disorder, PTSD, eating disorders, premenstrual dysphoric disorder, and social anxiety disorder. Off-label uses, you can also use SSRI antidepressants for ADHD, insomnia, chronic pain syndromes, seasonal affective disorder, behavioral problems in individuals with dementia and intellectual disability. So they are giving it to people with intellectual disabilities. They're also giving it to people with dementia caused by Alzheimer's disease to treat seasonal affective disorder and whatnot. Half-life, there are three different types of SSRIs. There's short-acting SSRIs like Paxil and Luvox. If you miss a dosage of Paxil or Luvox, then you're going to develop symptoms right away. The moderate SSRIs are Zoloft, Celexa, and Lexapro, and it takes it takes about half a day for you to start having, or maybe a whole day, missing your medication before you start having uncomfortable symptoms. And then there are the long-acting ones, and that's mostly people taking Prozac, which is one of the good things about Prozac. It stays in your system a little bit longer. So if you have somebody that's missing a lot of doses, they can't remember to take their pills, Prozac would be the drug for them. If it's somebody who doesn't have that problem, Zoloft is probably better. And Paxil is also fairly commonly given. Side effects: decreased sex drive and impaired sexual function tend not to be resolved with time. Nausea, diarrhea, anorexia, vomiting, all increase with dose that can be resolved with time. Weight gain, especially Paxil, paroxetine, after initial GI effects, and that has to do with vomiting and diarrhea, nausea. Headache, dizziness, anxiety, especially Prozac, fluoxetine, rash, insomnia, sedation, sweating, vivid dreams, tremor, dry mouth, especially Paxil, paroxetine, bruising, increased prolactin, um, protein that enables females to produce milk. So what does this mean? Well, you can deduce what it means. Drug-to-drug interactions. Luvox increases Prozac. It increases Paxil. It increases Zoloft. It increases Celexa. It increases Lexapro. The interacting effects may be dose dependent. That's especially with Zoloft. SSRI levels tend not to be altered by other drugs, but can potentially increase levels, inhibit the metabolism of certain drugs. So the doctor needs to, the pharmacist needs to be aware that that's the individual is taking an SSRI. Examples: Paxil increases risperidone, which is an antipsychotic. Prozac increases buspirone, which is an anxiolytic, and Luvox increases olanzapine, which is also a antipsychotic. Caution: suicidal ideation and increased suicide risk, especially with children early in treatment, but there is significant debate about how bad this is. Serotonin syndrome is where you mix an SSRI and an MAOI, and possibly lithium and maybe other drugs. Can cause diarrhea, tremor, sweating, restlessness, hyperreflexia, which leads to progression of symptoms if it's untreated. And of course, that's one of the things that you need to tell people if they are on a SSRI, that if they start having diarrhea, tremor, sweating, restlessness, hyperreflexia, then they need to tell you, because the next stage of this is not just diarrhea and tremors. It's disorientation, rigidity, fever, which leads to coma, seizures, which lead to death. If you get the serotonin syndrome, if you are too sensitive to these SSRIs, then 10% of the time it's going to kill you. So you need to be aware of what is happening. Many medications, substances have serotonin activity. Dextromethorphan, which is a cough medicine. Somebody's taking an SSRI, you probably don't want to do it. Fentanyl, of course, is dangerous to take with any medication. Meperidine, which is an opioid commonly called Demerol. You need to stay away from SSRIs. Somatropan, which is a migraine headache medication. Stay away from SSRIs. St. John's wort, which is an herbal antidepressant. Don't take two antidepressants at the same time. You may have a negative reaction. MDMA, LSD, anything that affects the serotonin, you really don't want to take your SSRIs with any of that stuff. Citalopram or Celexa, few drug-to-drug interactions, high serotonin specificity. It's typical or less SSRI side effects. Lexapro, no generic available. It's a fairly simple dosing. My wife was on Lexapro during her menopausal stage. She eventually decided she wanted to get off of it because she had to take it, and she didn't want to take another pill. Fluoxetine or Prozac has a very long half-life. It's significant drug-to-drug interactions with a lot of things. These are other names for Prozac: Seraphim, Symbyax, with Zyprexa. Luvox, it's used for obsessive-compulsive disorder. It has multiple significant drug-to-drug interactions, so you got to be careful with Luvox. Paxil or paroxetine has significant drug-to-drug interactions. Some reports of associated weight gain with Paxil. You have withdrawal symptoms with missed doses, so you need to be really careful with Paxil. Zoloft or sertraline Moderate drug-to-drug interactions, multi-step dosing, of course. Newer antidepressants that are not or less serotonin specific or affect serotonin differently than SSRIs. One of them is Clozaril or Tracidone, which was developed in 1981. It is used for people with PTSD. It was used with combat soldiers from Vietnam. Wellbutrin was developed in 1989. 1993, Effexor was developed. 1994, Serotonin was developed. 1996, Remeron was developed. 2004, Serotonin discontinued, although generics are still available. And in 2004, Cymbalta, which has a commercial on television, interestingly enough. It is used with another antidepressant. So if your antidepressant isn't touching your depression, they tell you to start using Cymbalta. Mechanism of action: Effexor and Cymbalta are both serotonin and norepinephrine reuptake inhibitors, SNRIs. Remeron has a serotonin subtype and a norepinephrine activity. Tracidone and nifazodone have different serotonin activity than SSRIs do. Bupropion has dopamine and norepinephrine activity, and it is used as an antidepressant as well. Indications and off-label uses: all typical and atypical antidepressants have FDA approval to treat depression. That's all the drugs that we've talked about up to this point. SNRIs have been shown to be effective in chronic neuropathic pain, neuralgia. Wellbutrin has been approved to treat nicotine addiction. Wellbutrin can augment SSRIs to reduce selective serotonin reuptake inhibitor sexual side effects. Remeron and Tracidone are used to treat insomnia. Both atypical antidepressants have many similar uses to typical SSRIs. Wellbutrin, Remeron, Tracidone, and nifazodone do not usually have associated sexual dysfunction, and a lot of people complain about it. You get depressed in your 20s, and all of a sudden they hit you with an SSRI, and now all of a sudden you have no sex drive whatsoever. So if people are complaining about this, then there are other drugs out there that they could potentially take. Venlafaxine or Effexor is similar to tricyclics with less safety and side effects concerns. Effexor has FDA approval for depression and generalized anxiety disorder and social anxiety disorder. This is what my wife actually took, Effexor. As an SNRI, Effexor activity depends on dose. Effexor has a minimal drug-to-drug interaction. Effexor has side effects with missed doses, and that's what happened with my wife. She went to a conference and she forgot her Effexor, and wow, she started having symptoms after about 2 days. Cymbalta is an SNRI that has minimal dose dependency. Cymbalta is indicated for depression and chronic neuropathic pain. Bupropion or Wellbutrin or Zyban. Bupropion is a norepinephrine and dopamine reuptake inhibitor. Zyban is used to treat smoking addiction. Bupropion is a seizure risk in certain patients in high doses. Bupropion's drug-to-drug interactions are not often significant except with MAOIs. Remeron is a complex serotonin that has norepinephrine alpha-2 and histamine activity. Mirtazapine has receptor activity changes with changes in dose. Mirtazapine has sedation and weight gain, especially at lower doses. Mirtazapine usage can have lipid abnormalities. Remeron has minimal drug-to-drug interactions except with MAOIs. Nifazodone or Serotonin is rarely used due to irreversible liver toxicity. Nifazodone was pulled from market by initial manufacturer in 2004, although it is still available as a generic. Nifazodone is still popular with some patients because it works, despite the fact that it destroys your liver. Tracidone or Clozaril causes sedation, weight gain, low blood pressure. Tracidone is used most commonly off-label for insomnia, and that's what it was being used for with combat veterans from Vietnam. Rare reports of sustained painful erection, priapism that should be treated in the emergency room. It can, of course, lead to impotence, and it has been reported with Tracidone. Tricyclic antidepressants describe a group of drugs with similar structure and function. It's abbreviated as TCA. In 1958, imipramine failed investigation as an antipsychotic, but was found to have an antidepressant property. 1960s, multiple other tricyclic antidepressants were developed and placed into use. So imipramine was the first tricyclic. 1990s, significant reduction in use due to introduction of SSRIs, which have fewer side effects. I started in medicine in the 1970s, so when I was working, especially in the beginning, the only antidepressants that they had were tricyclic antidepressants. Or the ones that were being used were tricyclics, actually. Maois still existed, but there were so many problems with it. It was mostly tricyclics. The mechanism of tricyclic antidepressant action, there is a norepinephrine, serotonin, histamine, muscarinic, and alpha-adrenergic receptor activity in differing ratios. Anticholinergic activity leads to many of the side effects of these drugs. It is used for depression and similar spectrum of disorders as SSRIs. Tricyclics are especially helpful with chronic pain and depression secondary to medical conditions such as AIDS. Side effects include enuresis, inability to pee, narcolepsy, premature ejaculation, insomnia, migraine prophylaxis. Blood may be obtained to monitor dose effectiveness, and that's when I first came in contact with imipramine and nortriptyline. Drug-to-drug interactions for tricyclic antidepressants. Tricyclics have multiple significant interactions in each direction with potentially serious consequences. Side effects of tricyclics for anticholinergic problems include dry mouth, constipation, blurred vision, and urinary retention. Cardiac arrhythmias and conduction changes, orthostatic hypotension, sedation, and weight gain. Cautions when taking tricyclic antidepressants. Overdose is frequently fatal. Patients with bipolar disorder may be pushed into mania or rapid cycling. So it is not used with bipolar disorder. Amitriptyline or Elavil is low in norepinephrine activity, low in serotonin activity. It has high anticholinergic effects. It blocks acetylcholine, and high in pain control. Amitriptyline is used to manage major depressive disorders, anxiety disorders, migraine headaches, and neuropathic pain. It's used to treat obsessive compulsive disorder, depressive disorder, panic attacks, and anxiety. Disopramine or norpramine is high in norepinephrine activity, low in serotonin activity. It has low anticholinergic effects and low in pain control. Disopramine is used as an antidepressant and to treat ADHD. Doxypin or Sinequan is low in norepinephrine activity, low in serotonin activity. It has moderate anticholinergic effects and low in pain control. Doxypin is used to treat major depressive disorder, anxiety disorders, chronic hives, and insomnia. Imipramine or tofranil is low in norepinephrine activity, low in serotonin activity. It has moderate anticholinergic effects and moderate in pain control. It's used to treat depression, anxiety, and panic disorders and enuresis. Amoxapine or ascendin is high in norepinephrine activity, low in serotonin activity. It has moderate anticholinergic effects and low in pain control. Amoxapine works as an antidepressant rapidly in 1 to 2 weeks and has been used as an antipsychotic. Clomipramine or anafranil is low in norepinephrine activity, high in serotonin activity. It has high anticholinergic effects, blocks acetylcholine, and high in pain control. Lutamil is high in norepinephrine activity, low in serotonin activity. It has low anticholinergic effects and moderate in pain control. Methylphenidate is used to treat depression, anxiety, panic disorder, and neuropathic pain. Nortriptyline or Pamelor is moderate in norepinephrine activity, low in serotonin activity. It has moderate anticholinergic effects and moderate in pain control. Nortriptyline is used to treat depression, anxiety, ADHD, neuropathic pain, and to help in smoking cessation. Protriptyline or Vivactol is high in norepinephrine activity, low in serotonin activity. It has moderate anticholinergic effects and low in pain control. Protriptyline is used to treat depression, ADHD, and its energizing effect is used to treat narcolepsy. Trimipramine or Surmontil is low in norepinephrine activity, low in serotonin activity. It has high anticholinergic effects and high in pain control. Trimipramine is used to treat depression, anxiety disorder, psychosis, and insomnia. The monoamine oxidase inhibitors are abbreviated as MAOIs. 1952, they were the first MAOI found with antidepressant properties is in process of looking for an anti-tuberculosis drug. So the tricyclics were supposed to be an antipsychotic, and monoamine oxidase inhibitors were supposed to be a tuberculosis drug. A 1962 investigation of a death from hypertensive crisis by someone ingesting tyramine-rich food while taking an MAOI. 1960s institution of strict dietary restriction of tyramine-containing foods and other interacting substances. 1960s significant reduction in the use due to introduction of tricyclic antidepressants, which do not have the severe restrictions of MAOIs. 2006, transdermal selagelene patch, MSAM, was developed. It's an MAOI to treat depression. If nothing else works, then take the MAOI. MAOIs are effective antidepressants for those who can adhere to necessary restrictions and tolerate many other side effects. There's very long duration requiring caution when mixing with restricted substance or medications. You have to be careful what you are around and what you eat. Tyramine-containing food, not a complete list. Certain tyramines can be consumed in moderation. Many cheeses, chocolate, soybeans, hot dogs, dry sausage, caffeine, beer, wine, pickles, olives. These all contain tyramines, and these are something you have to stay away from. Drug-to-drug interactions with MAOIs, everything. Multiple prescribed and over-the-counter medications can be potentially lethal with MAOI. So if you're taking an MAOI, stay away from everything. Serotonin syndrome with SSRIs and many others. So you've got to be really careful if you're on this stuff. Now, why in the world would we put somebody on an MAOI? Because they're not reacting to any other antidepressant. That's the only reason to give somebody an MAOI. Available formulations, phenylzine, Nardil, isocarboxylase, carboxazide, Marplan, and tranylcypromine or Parnate. Nardil, Marplan, and Parnate. And now we have a new one, Eldepril, Selagelene, is similar to MAOIs. Selagelene is used to treat Parkinson's symptoms. Selective B inhibitor at low doses, so restrictions are not critical. At high doses, it can act like a typical MAOI, and so there is a need for restrictions, so you have to be careful. Recently, there's a transdermal patch, MSAM, to treat depression and not needing food restrictions at low doses, although there are still drug interactions. So you have to be really careful with this stuff. Reversible selective A inhibitor is not available in the United States, and of course, you can't get it. Mood stabilizers. So the bottom line to MAOIs are stay away from them if you possibly can. It was the first antidepressant, the first real antidepressant. Then tricyclics came onto the scene, and then now SSRIs and SNRIs. So you would probably try SNRIs and SSRIs, and then if those two didn't work, then maybe tricyclics. If that didn't work, then maybe an MAOI. Stay away from it. Mood stabilizers are used to treat bipolar disorder. Many mood stabilizers are used to treat various seizure disorder types, migraines, chronic pain syndromes, aggression, impulsivity, augmentation of antidepressants, and antipsychotics. Other classes of meds are also used in bipolar treatment, usually in combination with mood stabilizers. Mood stabilizers are used in the treatment of acute mania versus prophylaxis versus depression. Lithium carbamazepine and valproic acid. In 1949, lithium was recognized as an anti-manic drug. In 1949, lithium toxicity identified after being used as a substitute for sodium in salt. The idea was we could control people's manic behavior by instead of using sodium in salt, by using lithium in salt. And then they realized, oh my God, this is the dumbest thing in the world. We're killing people. 1966, French researchers demonstrate valproate's efficacy in treating mania. 1978, significant studies demonstrate lithium's efficacy in bipolar disorder. 1980, studies demonstrate effectiveness of carbamazepine in bipolar disorder. So we used to use it for mania. This started in the 1940s. And then in 1978, we realized that lithium actually worked with bipolar disorder. So now all of a sudden, we're using lithium. And then in 1980, we realized, wait a minute, this anticonvulsive carbamazepine works with bipolar disorder as well, as does valproic acid. Lithium is the only mood stabilizer without significant anticonvulsant properties, up to 70% response rate, which is pretty good if you think about it. So you've got 100 people suffering from bipolar disorder. 70 of them will respond to lithium. Lithium has demonstrated effectiveness in reducing suicidality. And this is a really serious problem with people with bipolar disorder. When people with bipolar disorder start taking their medications, they start feeling better. They're not having any depression, they're not having any manic phases, and they think they're healed, that a miracle has occurred. So they go off their medication, and all of a sudden they have a manic episode. People with bipolar disorder commit suicide a lot, and mainly it's because they feel dulled by their treatment, by the lithium. Less effective in rapid cycling and mixed bipolar states. The full clinical effect may take up to 1 to 2 months. Serum levels guide dosing, and this is one of the things. This is how I first came in contact with lithium and bipolar disorder. We had to monitor people who were on lithium and I was a lab tech, so that was my job. Excreted through the kidneys. Lithium is excreted through the kidneys, minimal liver-mediated drug-to-drug interactions. So there you go. Lithium, pretty good drug. Fine tremors, weight gain, nausea are the side effects of lithium. Increased thirst and urination. More severe toxicities include coarse tremors, gait instability, vomiting, diarrhea, and confusion. Increased risk of toxicity with fluid or salt restriction. Hot weather sweating, use of anti-inflammatory drugs, ACE inhibitors, and angiotensin receptor blockers, and diuretics. So you gotta keep the fluid flowing in these guys. If they sweat too much, then potentially they can have some of these ugly side effects. It may cause kidney and thyroid dysfunction, so there is a need for regular monitoring of the creatinine and BUN, which are kidney functions. And BUN stands for blood urea nitrogen, and TSH are necessary. TSH, of course, is a thyroid function. Females are at much greater risk of lithium-related thyroid dysfunction than men are because men have more mass and more fluid in their bodies. Carbamazepine Ortegratol is used in acute mania and bipolar maintenance. It's more effective than lithium in rapid cycling in mixed states. Less effective in bipolar-related depression. Serum levels can be helpful in guiding dosage. Multiple significant drug-to-drug interactions affecting both other medications, reducing their levels, and other medications affecting it, increasing the carbamazepine levels. It induces its own metabolism, so it may need to adjust the dose over several weeks. Carbamazepine, which is an anticonvulsant. So it's also given to people with epilepsy. Side effects, gastrointestinal problems, nausea, constipation, diarrhea, appetite loss, central nervous system, sedation, makes you feel dull. This is the problem with people with bipolar disorder. They feel sedated, they feel dulled, unsteady, confusion, dizziness. Benign rashes are common. Catastrophic rashes are rare. Many possible serious abnormalities in their CBC. CBC is the complete blood count, where we look at the red cells. It's mostly the red cells that we see the abnormalities. They may reduce sodium levels, hyponatremia. Liver function abnormalities are rare but possible. Toxic metabolites, 10 to 11 carbamazepine epoxide, can create problems via drug-to-drug interactions with valproate, lamotrigine, and phenobarbital. It's independent of carbamazepine levels and can be checked separately. So you need to check all of these things. If somebody's on any of these medications, these are both anticonvulsants. Phenobarbital is another sedative. Valproic acid, also known as valproate, and Depakote can be dosed rapidly to treat acute mania. This is another anticonvulsant, by the way, so it's also used to treat epilepsy. It is more effective than lithium in rapid cycling in mixed states. It is used by some to treat aggression and impulsivity and other psychiatric disorders. It is approved for migraine prophylaxis. Prophylaxis means giving somebody something so that they don't develop the disease. That's a prophylaxis. So migraine prophylaxis would be that you would give them valproic acid to keep them from getting migraine headaches. Serum levels can be helpful in guiding dosing, commonly used at top or above levels stated for seizure control. Some suggest supplementation with carnitine, selenium, and others to reduce side effects. And of course, those are both metals, carnitine and selenium. Side effects of valproic acid: nausea, weight gain, unsteadiness, ataxia, hair loss, tremors, liver dysfunction, decreased platelets known as thrombocytopenia, pancreatitis, rare but potentially serious. That's an infection of the pancreas. Polycystic ovary disease suggested by some reports. Ammonia levels can be increased, particularly in those rare individuals with genetic metabolic deficits. Drug-to-drug interactions by various mechanisms with numerous other anticonvulsants, aspirin, and others. Lamotrigine, oxcarbazepine, topiramate, 1990s lamotrigine investigated for mood-stabilizing properties after patients on it for seizure disorder report benefits. This is in the 1990s. Also in the 1990s, most newer approved anticonvulsants are investigated for mood-stabilizing properties. In 2003, lamotrigine approved for bipolar 1 maintenance. Lamictal is another name for lamotrigine. Minimally sedating, unlike most other mood stabilizers. People like that. It appears to be especially effective in treated bipolar depression, but unproven to treat mania. Early use as an anticonvulsant in children raised concerns about potentially life-threatening rash. This is known as Stevens-Johnson syndrome or toxic epidermal necrolysis. Initiating lamotrigine is done very slowly to decrease rash risk. And of course, one of the things that they do is they don't try not to give this to kids. If the valproate and the Tegretol don't work, then potentially they'll try this stuff. Valproate greatly increases lamotrigine levels. Carbamazepine greatly decreases lamotrigine levels. Oxcarbazepine trileptal is used primarily in combination with other mood stabilizers, although efficacy not clearly substantiated. It's modified carbamazepine with potentially less side effects and drug-to-drug interactions than carbamazepine. 10-11 carbamazepine epoxide, not a metabolite, so higher dose required if switching from carbamazepine. Topamax research questions its use as a mood stabilizer, although scattered reports suggest possible benefits. Weight loss, cognitive dulling, kidney stones, and metabolic acidosis. Not good things. Keppra, efficacy in bipolar disorder unsubstantiated, although scattered reports suggest possible benefits. Minimal drug-to-drug interactions. These are all they call them mood stabilizers, but they're anticonvulsants. Zonegran, efficacy in bipolar disorder unsubstantiated, although scattered reports suggest possible benefits. Side effects similar to topiramate, including weight loss. Olanzapine and fluoxetine combination, it's known as Symbyax. Olanzapine and fluoxetine are both SSRIs. They're approved to treat bipolar depression. Antipsychotics. Now we're going to talk about the older antipsychotics. Of course, once upon a time in the world of mental illness, schizophrenia was the main thing that we were looking at. So we were looking for an antipsychotic. As you remember, one of the tricyclics were thought to be an antipsychotic. Turned out to be an antidepressant. But, of course, we're always looking for something that works. So in 1950, chlorpromazine was synthesized as a sedating antihistamine. In 1952, chlorpromazine reported to be beneficial in psychosis and mania. Excuse me. 1953, first reports of chlorpromazine-associated movement disorders. 1958, haloperidol was developed. 1962, long-acting injectable fluphenazine was developed. In 1970, dopamine hypothesis of schizophrenia was suggested. 1970. In 2005, the CATIE trial shows a positive outcome for perfenazine compared to newer antipsychotics. So we're going to talk about the older antipsychotics and the newer antipsychotics. Older antipsychotics, neuroleptics, seize the neuron, referring to the tendency to cause stiffness and other neurologic symptoms. Early symptoms of dosing would achieve neurolepsis and then backdose down to relieve these symptoms. In other words, what they did, they made them neuroleptic. They made them stiff. They tried to make them relatively non-functional. Then they backed the dosage up to find the proper dosage to use for the individual. Sorry. Major tranquilizers refers to the tendency to sedate, quiet, and create a blandness in patients similar to the negative symptoms of schizophrenia. Differentiates from benzodiazepines such as Valium, which were referred to as minor tranquilizers. So the first antipsychotics that were used were major tranquilizers. They tried to knock these people out pretty much because they couldn't control them. And so controlling them was the most important thing. Typical traditional conventional antipsychotics differentiates these drugs from newer atypical antipsychotics. Dopamine receptor antagonist highlights strong dopamine activity and tight binding to D2 receptors. Side effect terminology, extrapyramidal symptoms. Extrapyramidal symptom is responsible for voluntary movement. Pyramidal system is responsible for voluntary movement. Extrapyramidal system responsible for involuntary muscle action. It includes dystonias, Parkinsonism, akathisia, and tardive dyskinesia. Acute dystonia, sustained muscular contraction of neck, eyes, and throat. It generally occurs soon after starting your medication. You have acute dystonia. Akathisia, uncontrollable continuous motor restlessness, can occur anytime at treatment, but generally in the first few weeks. It's easily misdiagnosed as underlying psychiatric disorder, akathisia. Parkinsonism, tremor, muscle stiffness, slowed movement, drooling, generally occurs beyond 1 week after starting medication. And tardive dyskinesia, spastic facial distortions and tongue movements. It may extend to neck, trunk, and extremities. Delayed effect, usually beyond 6 months from starting medication. Risk increases with duration of exposure to antipsychotics. Known to occur without antipsychotic therapy to tardive dyskinesia. It may be permanent, occur on discontinuation, or resolve on its own. It is worsened by medications used to treat other EPS, extrapyramidal symptoms. Neuroleptic malignant syndrome, pipe-like rigidity, fever, tremor, altered level of consciousness, hypotension, tachycardia, laboratory abnormalities, elevated white blood cell count, and creatinine phosphokinase, or CPK. Actually, they call it CK now. Creatinine kinase is what they call it now. It used to be creatinine phosphokinase when I first started in medicine. Mortality, 10 to 20% for neuroleptic malignant syndrome. Can occur anytime in course of treatment. Anticholinergic effects, dry mouth, blurred vision, constipation, urinary retention, mydriasis, dilated pupils. Methods of classification, clinical effect and potency. Low potency, chlorpromazine, mesoridazine, and thyroidazine. Medium high sedation, low medium extrapyramidal symptoms, high anticholinergic effects. Medium potency, perfenazine, loxapine, and molindone. These are all antipsychotics, okay? Low medium sedation, high extrapyramidal symptoms, low medium anticholinergic effects. High potency, flufenazine, fluoperazine, and thiothiazine, haloperidol, and pimazide. Some of these are all new, and that's one of the reasons I can't pronounce them very well. The old ones I can pronounce without any problems. Medium-low sedation, high extrapyramidal symptoms, low anticholinergic effects. Chlorpromazine or thorazine, cardiac risk and weight gain. These are the older antipsychotics. Flufenazine or prolixin, long-acting injecting available. Halperidol or Haldol, long-acting injection available. Loxapine, Loxetane, mesoridazine or Serotil, cardiac risk. Moban or molindone, parafenazine, trilofon, pimozide or ORAP, cardiac risk. Thioridazine or Mellaril, there you go, high cardiac risk. Navane or thiothiazine, and stelazine or trifluoperazine. A lot of times I know them by these names and not these names, but I'll try to say them anyway. Clozapine, the newer antipsychotics, there are newer antipsychotics, and these are the ones that we use more often than anything else. Clozapine is introduced in the United States after a long delay related to safety concerns. Risperidone, 1994, 1996, olanzapine, 1997, quetiapine, 2000, ziprasidone, 2003, aripiprazole, 2004, ADA, APA, consensus report on obesity and diabetes in those taking antipsychotics. I worked in medicine until about 2000, 2001. Terminology, atypical antipsychotics, second generation antipsychotics, serotonin dopamine antagonists. The mechanism, it adds serotonin activity. It binds more loosely to dopamine receptors. Clozapine initially rejected as an antipsychotic because of its seemingly reduced dopamine impact and lack of EPS, extrapyramidal syndrome. Indications, uses, schizophrenia and other psychotic disorders, of course, acute bipolar mania and maintenance. Augmentation of antidepressants and mood stabilizers, aggression, and impulsivity. Features is less risk of EPS movement disorders, greater effect on negative symptoms of schizophrenia. Cautions, greater risk of obesity, diabetes, and lipid abnormalities. Clozapine affects olanzapine, affects quetiapine. Risperidone affects ziprasidone and aripiprazole. It requires regular monitoring of metabolic parameters. Potential stroke, mortality risk in the elderly, EPS, movement disorders, and NMS all can still occur, although much less than atypical antipsychotics. These are some you may have heard of. Abilify, of course, has a commercial on television. Unique complex mechanism can be either activating or sedating. Nausea is common with Abilify. Clozaril, another one that you've probably heard of, most effective antipsychotic. Risk of agranulocytosis, decreased neutrophilic white blood cells. They're the ones that fight bacterial infections. CBC weekly for 6 months, biweekly for 6 months, then monthly after that, to make sure that they are not developing agranulocytosis. Multiple other side effects and DDI, that's drug interactions, drug-to-drug interactions. Levels reduced by smoking. Olanzapine, Zyprexa, significant weight, diabetes, and lipid abnormality risk. Levels reduced by smoking, once again. Seroquel, approved dose range considered low by many, low EPS risk. It's used commonly as a sedating agent. Risperidone or risperidol, most likely typical antipsychotics at higher doses. It's available in long-acting injection, and this is known as Consta. Giadon is approved dose range considered low by many. Initial cardiac concerns appear insignificant for most. Must be taken with fat-containing meal or snack. Anticholinergics, benztropine, cognitin is least sedating, most commonly used. Quinton, Benadryl, Artane, Simetrol. Not a anticholinergic. It's used rarely to treat EPS, the extrapyramidal symptoms. Treats tremor, stiffness, drooling, dystonias. Akathisia may not respond to anticholinergics. Tardive dyskinesia may worsen with anticholinergics. Dry mouth, constipation, blurred vision. Extrapyramidal symptoms thought to be cholinergic, dopamine imbalance. Benzodiazepines. The first benzodiazepine was Librium. In 1957, 1970s, Valium, diazepam became the top-selling drug in the United States. 1986, Xanax was developed, alprazolam, and then it became the top-selling drug in the United States. Right now, the top-selling drug in the United States is Viagra. 1990s, SSRIs replaced some chronic benzodiazepine use for anxiety. General characteristics of benzodiazepines: it differs in action, duration, drug-to-drug interactions, and side effects based on the differences in absorption rate, lipid solubility, and metabolism. Indications, uses include anxiety disorder, panic disorder, mania, seizure disorder, phobias, insomnia, alcohol withdrawal, muscle spasm, agitation, catatonia, akathisia. Hospital use, we put benzodiazepines in IVs. We give it to people intramuscularly for sedation purposes. Side effects: sedation, cognitive impairment, anterograde amnesia. What happened? Respiratory depression at high dose or with alcohol. It may worsen obstructive sleep apnea symptoms in susceptible individuals. Abuse and dependence. Risk of abuse is small in individuals who are not abusing other substances. Withdrawal symptoms and physical dependence are not in themselves problematic if reductions are done gradually to minimize symptoms. Use of longer acting agents to minimize between dose breakthrough and avoiding taken as needed dosing are helpful. Symptoms of withdrawal may represent breakthrough of the underlying anxiety disorder. Needing to increase the dose tolerance, not generally an issue at therapeutic doses. Xanax is a short to mid acting benzodiazepine. Librium, long. Klonopin, mid to long. It has serotonergic properties. Transine, long. Valium, long. Prosom, mid. Dalmane, long. Ativan, short to mid. Sirac, short to mid. Restoril, mid. And Halcyon, short. So if you came into the emergency room and you were having panic disorder, we'd probably give you Ativan. Or in the old days, we'd give you Ativan. I'm not sure what they're doing now. Other anxiolytic hypnotics, chloral hydrate was the first one developed. Chloral hydrate is kind of interesting. It's 3 molecules of alcohol fused together. 1992, Ambien was approved. 2006, Zolpidem or Ambien, the generic was developed. Hypnotics are medications that induce sleep. Non-benzodiazepine anxiolytics include buspirone and antihistamines. Newer anticonvulsants are used off-label as both anxiolytics and hypnotics. although efficacy is unproven. Tracidone and some tricyclic antidepressants are used as hypnotics. Newer hypnotics active at GABA1 receptor, except for Rimeltion. Other anxiolytics, miscellaneous buspirone or Buspar is a subtle anxiolytic and slow responder. Chloral hydrate, Noctec is a hypnotic, rapid tolerance and toxicity in overdose if you're not careful. Antihistamines, Vistaril and Benadryl, anticonvulsants, mildly sedating and calming, Neurontin, Lyrica, and Gabatril. Selective benzodiazepine receptor activity, GABA1, hypnotics, Lunesta, long-term use approval, Sonata, short half-life, and Ambien or Zolpidem. Melatonin receptor agonist, Rosaram. The stimulants, ADHD drugs, Ritalin approved in 1956. 10% of 10-year-old boys in the United States are on stimulants at this point. 2.5 million children in the United States are on stimulants. Recent FDA warning about increased cardiovascular risk, sudden death for patients on stimulants. Strattera is a non-stimulant treatment for ADHD. It's a recent caution about suicidal ideations in these individuals. There are rare liver function impairment. Catapress is another ADHD drug, antihypertensive alpha 2 agonist. It's used for ADHD, substance withdrawal, Tourette's syndrome, and other such problems. Cydalert or Pimolone, rarely used stimulant due to liver toxicity. Dexadrine, multiple long-acting forms. It causes insomnia, headache, tremor, exacerbation of tics, nausea, weight loss, blurred vision, overstimulation. Methylphenidate or Ritalin has the same reactions as dextramphetamine or Dexadrine. Provigil or modafinil, non-stimulant. It's poorly understood mechanism of action. It's used for sleepiness related to narcolepsy, obstructive sleep, apnea, and depression, and multiple sclerosis. It's used for ADHD, is being investigated. Medications for dementia, the first one was Cognex in 1993. And I was still working in medicine at the time. I was working in Oklahoma, and this hit our town like a rocket. We had so many people that were suffering from Alzheimer's disease. So a lot of people started taking Cognex. 1996, Aricept was approved. In 1997, generalizability of approval studies was questioned. 2003, Namenda was approved for moderate to severe Alzheimer's dementia. 2004, detailed British study questions efficacy of cholinesterase inhibitors. The general characteristics of medications for dementia. The search for a treatment for Alzheimer's dementia is driven by intense human suffering and immense demographic numbers. Studies that support use of these medications generally find subtle benefit or slowing of decline. There is significant debate about the benefit versus cost, money, and side effects of using these medications. Treatment for behavioral issues in dementia has been complicated by FDA warnings about the risk of using antipsychotics in the elderly. Cholinesterase inhibitors address one theorized mechanism of this complex disease. Aricept, Rimonil, Exelon, Cognex. They're rarely used due to liver toxicity. Now, Namenda is a complex activity via NMDA, the glutamate-mediated receptor. It may have more broad psychiatric application. Use of medications in substance abuse, treat withdrawal symptoms, benzodiazepines, anticonvulsants, and clonidine. To treat comorbid psychiatric disorders, anxiety and depression are common. SSRIs, mood stabilizers, and benzodiazepines. To prevent relapse, deterrence, and craving control. Disulfiram antabuse is a deterrent. It requires a motivated patient. It makes you sick. It makes you vomit if you drink alcohol. Camprol is a craving control. It has minimal drug-to-drug interactions. Efficacy is shown in some studies with more severe alcoholics, although other studies question its efficacy. Naltrexone is an opioid antagonist. It has a high response for placebo cause, some to question study design. Potential liver toxicity, Vivitrol, injectable naltrexone lasts for about 30 days. Naloxone, buprenorphine, Suboxone, treatment for opioid dependence, contains both an antagonist and an agonist. Zyban is identical to Wellbutrin. It treats nicotine craving. Others, several anticonvulsants, topramate, etc., have been used for craving reductions. The uses of these drugs are off-label and carry additional potential side effects from their cardiovascular actions. Potential psychiatric benefits have often been discovered while these agents were used for their primary indication. Monitoring blood pressure. These are the antihypertensives. Alpha-2 adrenergic agonists, clonidine, guanfacine, and prazosin are used in ADHD, Tourette syndrome, and PTSD. Prazosin is found helpful in reducing PTSD-related nightmares. Beta blockers, propranolol, Inderol, are used for akathisia, lithium-induced tremors, performance anxiety, and aggressive behavior, hyperarousal. Pindolol has been considered for antidepressant augmentation, multiple drug-to-drug interactions, avoid in asthma, diabetes on insulin, certain cardiovascular diseases, calcium channel blockers, ditalizim, verapamil, nimodipine, may be helpful as additional agent in bipolar maintenance, multiple drug-to-drug interactions, and precautions. And that is it. And I did it. I got it in less than an hour, or maybe it was an hour. Anyway, had a good time this semester. This is the last lecture. I'll see you guys next year. I'll see you next semester, I guess, or maybe if you're taking a class in the summer. I'm teaching all the psych classes this summer.